everyone. It's 9:40 a.m. and I imagine that we will still have some folks joining us in the next few minutes. Before we get started, and if anyone on this call doesn't know me, I'm Elizabeth Doolin. I'm the Director of Young Adult Ministry at Idlewild. I kind of pop in and pop out. I will be the support teacher this morning, but I have an announcement for y'all from Anne regarding worship this morning. Currently, the live stream is not cooperating, so be prepared to do worship a little differently today. That's just sort of the nature of everything in this time. Things are constantly changing. So worship will either happen in one of two ways. We will either divide the worship recording into two parts, and members will have to go to live stream and push play twice. That's one option. Another option is that the worship video will be on Idlewild's YouTube site, and you can go to YouTube and search for Idlewild Presbyterian Church, and today's service will be posted there. Currently, Jenny and Ann are working to see which of these options will be better, and a congregational email will go out telling you which one of these we will be doing. So if y'all could share that with any of your friends or let people know on social media to be on the lookout for instructions regarding worship this morning, that would be helpful. So we know that it's going to cause additional confusion, even more so than the changes we've already had to make this weekend. So thank you all for sticking with us in this time. All right, so I'm going to get us started with our Lectio Divina this morning. And it really helps me to be able to read the words of this. So I'm going to share my screen with y'all in just a moment. All right, and our Lectio Divina this morning is a little longer than it usually is, so hope you stick with it. Our scripture comes from the book of James, chapter 1, verses 22 through 25. But be doers of the word, and not merely hearers who deceive themselves. For if any are hearers of the word and not doers, they are like those who look at themselves in a mirror. For they look at themselves and, on going away, immediately forget what they were like. But those who look into the perfect law, the law of liberty, and persevere, being not hearers who forget, but doers who act, they will be blessed in their doing. And then our contemporary wisdom comes from Dr. Reggie Williams, who is a professor at McCormick Theological Seminary. And this passage is from a recent article of his in the Christian Century. Prejudice alone is not white supremacy. It is vital to understand the difference. Any individual may harbor unfounded bias or contempt toward a person or group of people. And while an individual's affect toward others can change, that is not the kind of transformation that will end white supremacy. No amount of hugging will eliminate it, because white supremacy is not about affect, it's about anthropology. How do we understand what it means to be human? The historical answer to that question has been a hegemonic one: white supremacy. I'm going to let y'all sit with that for just a minute. I invite you now to respond in the chat with a word or phrase that is speaking to you this morning. I see being not hearers who forget, but doers who act. Be doers of the word. Be blessed in their doing. Law of liberty. Forgetfulness. Hope. Doers, hegemony, what it is to be human. Doers, be doers of the word. This word is standing out today. Be doers of the word and not merely hearers. No amount of hugging will eliminate it. Seeing yourself in the mirror, the kind of transformation. Not hearers, but doers. Hearers who deceive themselves. The hegemonic one. And I read through both of these one more time. But be doers of the word and not merely hearers who deceive themselves. For if any are hearers of the word and not doers, they are like those who look at themselves in a mirror. For they look at themselves and, on going away, immediately forget what they were like. But those who look into the perfect law, the law of liberty, and persevere, being not hearers who forget, but doers who act, they will be blessed in their doing. Prejudice alone is not white supremacy. It is vital to understand the difference. Any individual may harbor unfounded bias or contempt toward a person or group of people. And while an individual's affect toward others can change, that is not the kind of transformation that will end white supremacy. No amount of hugging will eliminate it, because white supremacy is not about affect. It's about anthropology. How do we understand what it means to be human? The historical answer to that question has been a hegemonic one, white supremacy. I'll give you all one more minute to sit with those. Okay. Now, if you could share in the chat how you feel that God is speaking to you through this Lectio Divina this morning. See, change must be deeper than feelings. Transformation requires action to effect change. Forget what they were like. What I'm willing to concede in order to dismantle the hegemony of white supremacy and my complicity in it. What is IPC willing to concede in order to do the same? Law of liberty demands action toward ending white supremacy. How does one work to end white supremacy? Not sure I fully understand the claim about the answer about what it means to be human. Okay. Sometimes I do not see the blessings of doing, like putting up the BLM sign, and yet I know it must be there. We are called to be doers. Anti-racism takes doing, must act and not just think about it. All right. Thank you all for sharing this morning. I'm going to stop my screen share now, and I'm going to hand it over to Kendra Hotz.
Good morning, everyone. It's good to be with you today. Let me start a screen share, and what I'm going to do today is share some information about racism in healthcare. And this is quite different from what I normally do, because normally I'm looking at racism and health, not racism and healthcare. So give me a second to say why those two things are different. I cannot multitask. You can tell I can't talk and fix my screen at the same time. All right, ordinarily, what I spend my time thinking about is the way in which social forces shape our health. And so I'm looking about how differences in income and accessibility of housing and food, and how racism as a social force affects our bodies. And the phrase I often use for that is that we can measure the justice of a society in the bodies of its people. Today, what I'm going to be thinking about is how racism gets into healthcare and expresses itself there. And what I want to just clarify right at the beginning is that medicine has quite a small impact on our health compared to those other social forces. So just kind of a rule of thumb, about 80% of what determines your health outcomes, which diseases you get, what quality of life you have, whether your children survive to their first birthday, about 80% of that is socially determined. The other 20% is not medicine though. About 10% is quality of care. So what we're talking about here is something that has a small impact on health compared to other things. And so when I teach this material with healthcare providers, what I often say is that health disparities cannot be fixed by medicine because they're not a medical problem. They're a social problem. Medicine, however, can make it worse. And so what we're really doing is training in how to do no harm. How do you prevent yourself from exacerbating the situation? Now, I know that this is not a group of healthcare providers, although I see a good number of you on the screen who are healthcare providers. And so here the question is, why would faithful Christians want to know about this, right? Why would we make kind of racism in healthcare a topic that we need to be aware of? And the answer to that is something like, because it is one more instance of death by 1,000 paper cuts, right? It's not always the big injustices that are death dealing. It's instead the microaggressions. It's the everyday ways in which your humanity isn't recognized. And so what we need to be aware of is, here's one more place where our society is set up in a way that supports white supremacy. And there, by white supremacy, I don't mean, as the quote said, I don't mean an affect. I don't mean people who hold white supremacist beliefs. I mean a system, a structure that's supported by policies, by a culture, by a way of speaking, by the assumptions that we make about each other, about the way our bodies are legible to each other. And so this is sort of one more of those little cuts that undermines trust, that communicates to people that they are not regarded as valued, as normative in our society. So the opening slide here, this is a presentation I normally do for physicians, residents, medical students. And so it's a can of worms, because here we go. We're going to talk about racism in our own practices. We're just going to kind of tear the top off of that thing and look inside this can of worms. This week, I'm going to introduce you to some problems. And next week, I want us to talk about some potential remedies. Now, while I'm sharing my screen, it is hard for me to see you. And I don't want this to be a lecture. So when you have a thing to say, unmute yourself and jump in. I also have trouble monitoring chat while I'm sharing my screen. So if somebody sees something in chat I should be aware of, kind of like unmute yourself and yell at me to shut up, then I need to see what's in the chat. Okay, here we go. So this is a picture that a friend of mine took when he was in the emergency department. And he was in one of those kind of, those rolling gurney type things. And he's got the cloth room dividers for privacy. And he sees this sign, please undress and put the gown on facing toward the back. Thank you. And then Psalm 46:10. Now, I love this. If you look up Psalm 46:10, it does not say undress and put the gown on facing back. I don't suppose this is a group that happens to have that memorized. This is be still and know that I am God. Be still and know that I am God. So I'm trying to imagine how putting a Bible verse that people probably don't have a minute to look up is supposed to be comforting at the same time that you're being communicated. The communication to you is make yourself as maximally vulnerable as possible, right? When we look at these two terms, agents and patients, we're used to talking about ourselves as patients when we go into healthcare settings. But kind of classically, these terms mean an agent is someone who does a thing, and a patient is someone who has a thing done to them. So a patient is the recipient of someone else's agency. And when you think about healthcare settings, they are set up so that we hand over our agency to someone else. It takes a lot of trust to do that. When I think about when I come into a healthcare setting, the most common way for that to happen to me is, once a year I go in for an annual physical, and I come through the clinic doors and I am fully Kendra, right? I am thinking about, did I lock my bike up securely enough that I don't have to worry about it while I'm in here? Is Matt going to remember that this is the night that he needs to feed the dog because I'm going to be home late? Oh my gosh, am I ever going to get all those papers graded, right? I've got this full humanity. And as I move into the healthcare setting, little by little, we sort of strip away all of those distinctive things that are essential Kendra-ness, right? The first thing is just I'm separated by the glass window, even in pre-COVID time, from the insiders and the outsiders who are in the waiting room. And I have to hand over the card that proves I have a way of paying for this before they'll let me back. And then eventually my name gets called, normally mispronounced, because it looks like Hotz, not Hotz. I know that still irritates me. My name is Hotz, right? I've got a really good joke I tell students to make sure they don't mispronounce my last name, but I won't tell it in church. So you can figure that out on your own, right? So, they call me back and immediately I am measured in a relatively public space, right? I give over control of my tongue, my index finger, and my bicep, right? Think about that. Pulse oximeter, thermometer, blood pressure cuff. That's a pretty extraordinary level of control to give up to somebody who doesn't even know how to pronounce my name. And then I get led through this maze like a rat looking for the cheese into a tiny room with a table in it that looks like nothing so much as a butcher table. And it doesn't help that it's covered with butcher paper, right? I sit on the table exchanging my clothing for what amounts to a large paper towel and wait for somebody to come and do something to me. At the end of it, I'm allowed to put my stuff back on, the clothing that marks me as Kendra and not just one more, patient 492. And I try to get myself out of the maze, which I can never do. I always have to ask at the nurse's station, how do I get to the exit, right? All of that is to say that the setup there already transforms me into a patient, transforms me into somebody who will receive the action of someone else. Now, the question is, how is that relationship going to play out? Is this going to be a context of shared decision-making? Is this going to be a context in which my full humanity is recognized and valued? Is this going to be a context in which I can trust that my most basic bodily well-being is held as sacred by the person who comes to me as the agent of healthcare delivery, right? This is what we want to think about and how racism erodes that relationship. This is what we expect medical racism to look like. For those of you who aren't familiar with this, it was kind of a media scandal about a year or so ago. One of those two guys is Governor Ralph Northam of Virginia. And this is a picture from his medical school graduating yearbook. So we are looking at, physicians who have been in practice for a long time, who are just nearing retirement age, who have been the dominant factors in healthcare delivery for the past couple of decades at least. And right? This was so normal that it was okay for this to be a public picture in a med school yearbook. And by the way, you don't have to go back to, 1972 or something like that. You can still, in the last 10 years or so, find plenty of images sort of like this, normally Halloween in medical schools, where we still have mock lynchings and things like that. So it's not so much part of the culture of medicine to have a huge taboo on racism that even these most overt things don't show up. But this is not what medical racism normally looks like. Normally it looks more like this. So I don't know if you're going to be able to read this or not. It's tiny even on my screen. This is a nursing school textbook from 2017. It was actually out. It was pulled from the shelves in November of 2017. This is training in cultural competence. And so the idea here is that these are things that the nurses needs to learn about how different cultures respond to pain in order to take good care of patients from these different places. So now unmute yourselves and holler. I'm not going to ask you what's wrong, what's okay with this. There's everything about this total disaster. So I'm going to ask what's wrong? Like, what do you see that's just jumping off the screen at you? Just unmute yourself and say it.
Everybody's lumped into a category.
Okay,
so many assumptions.
And there's no white category.
Yeah, everyone just looks like a variation on the standard, which implicitly is white.
The assumption is that the nurse is white.
No whites. Yeah.
And it's all stereotypes, a lot of them.
Okay, everybody's in a category except white. White is not a category, right? White is an oppositional category. That's the way to think of it.
Native Americans, Asians, Blacks, and Muslims.
Yeah. Yeah.
And shouldn't it always bothers me that when you have categories of different people, they have, African Americans, Native Americans, Hispanics, Jews, and they have whites instead of Caucasians. I always scratch that out and then check the box on any form that I get like that. It really bothers me.
Hey, Kendra, as a representative of the Religious Studies Guild, I have to say that Arabs and Muslims are not the same.
Thank you.
Thank you. Yes.
In fact, most Muslims are not Arab, right? The overwhelming majority of Muslims are not Arab, and not all Arabs are Muslim. Thank you.
Well, another thing is they're not broken into men or women. It's all one. It doesn't take into account women have needs and men have needs.
Okay.
No,
women have a higher level of pain tolerance, by the way.
I'm sure they do.
Yeah, there's no different. We're not differentiating age here. We're not differentiating by gender expression. We're not. There are all kinds of ways we can differentiate. But then, if you also look at the content, this is going to get a whole lot worse, right? It essentially says that Black people exaggerate their pain. Yeah. Jews, it says, are vocal and demanding.
Yes, right.
Native Americans might choose a sacred number if you ask them to rank their pain between 1 and 10, right? Everything about this is just a total disaster. I promise you that these footnotes down here are going to be to reputable sources that do not say what is summarized in the bullet points. Okay, so the idea here is you can memorize a list of bullet points, and now you have cultural competence that will let you take good care of Jewish and Asian and Hispanic and Arab and Black and Native American patients. Why don't you need to know anything about white patients?
Because you're white and you already know.
Okay, maybe because you are white and you already know.
That's what I was going to say.
No
It is
special
assumed that
accommodations
white
that
is the norm.
you make, or no adjusting your mindset. Whatever the white person tells you is just straight up the real deal, and you only have to know about the variations to deal with them.
That's right. So
because white people handle pain appropriately, and there's nothing you would need to know about how white people handle pain.
White is the basis from which all of these things are measured.
Very good. White is baseline, white is normal, white isn't a culture. So a good joke at this point is to know that there's no like white aisle in the grocery store, right? You can go to the ethnic food aisle, but you can't go to the white aisle. If they had one, it would be the aisle that has no spices on it. Right, whiteness is taken as baseline. And so one thing we want to get used to here is that whiteness isn't what is present, whiteness is what is absent. So when we think of whiteness, we have to think of it as this oppositional category. You all learned that song when you were little, probably I did too, right? Red and yellow, black and white, they are precious in his sight. It gives the impression that Asian, Black, Indigenous, and white identities are parallels to each other. They are not, right? Whiteness is not parallel to Blackness. There's a reason we have a Black student association, but not a white student association, and why we shouldn't have a white student association, right? So when we're thinking about racial categories, it's actually in some ways good that whiteness isn't here, because whiteness is the page this is printed on, right? It's what's in the background of all of the other assumptions we make about how people are legible to us and how we respond to them. So, you know, I was working with some nurses in the ICU at Le Bonheur recently, and I showed them this and I was asking about it, and they said, oh, that's still, I know they pulled this in 2017, but I promise you there's still some version of this out there. And to, you know, pass your courses, you have to be able to take these multiple choice exams that show, you know, these things. And so many of them were expressing this sort of dismay that I had to pass the test. And so I gave what was the quote right answer, but, you know, find it appalling. So it's pretty typical. Okay, let's keep looking at some examples. This is a summary of a finding that was published by the Institutes of Medicine as a congressional report in 2003. It has the studies from, I know that's 17 years ago, but those studies have been replicated dozens of times since then. So this is kind of a summary of the findings. Compared with whites, African-American patients had lower rates of cardiac surgeries, fewer hip and knee replacements, fewer kidney and liver transplants. Diabetic Black patients were more often amputated than diabetic whites. Non-diabetic Blacks were amputated more often too. Blacks were more likely to receive open surgeries rather than the less dangerous laparoscopic procedures. Surgeons didn't operate them as often for equally operable lung cancers. They received less medication for the same injuries and diseases, and they were more likely to be castrated as a treatment for prostate cancer. So what the studies did was try to eliminate every medical explanation for these disparities. Could it be that the Black patients were presenting with greater acuity? So you control for that and say, okay, well, those surgeries weren't an option because, well, maybe it was because they had different kinds of insurance and we couldn't get this procedure paid for, but that one could. So you control for that. So what you do is control for everything that could legitimately explain these differences. And when you've controlled all of that out, you're still left with this summary of conclusions. And so what the summary of realities. And so the conclusion that the Institutes of Medicine drew, not known for being a kind of wildly liberal, flaming, anti-racist organization, the Institutes of Medicine concluded that it was unconscious bias that was driving these differences. The report was released first to the White House, this is 2003, and the White House redacted the report in order to remove the words bias and disparity from everything in the report. So it's 765 pages. And I sort of imagine if you redact disparities and bias out, you might get it down to like 500 pages, right? That's what the report is about. Someone leaked the report to the New York Times, and as a result, Congress had to release the entire report rather than the redacted version of it. So we've got this sort of claim that these disparities are being driven by bias. I heard somebody good.
Yeah, a question, Kendra, Charles Key. Is there anything in the study that addresses choice? Viewing this from the agency side, as you put it earlier, we have this, but from the patient side, are African-American patients choosing not to undergo cardiac surgery, choosing not to undergo knee replacements and so on?
Yes, they did look at that. And that is a complicating factor. I have a colleague, Christy Libford, who worked on studies and disparities on kidney transplantation for African Americans. And she did find that part of it could be explained by Black patients not choosing to follow through. The root cause, though, of the disparity in kidney transplantation was that Black patients weren't being referred into the system as often as white patients were. That partly has to do with the for-profit dialysis centers that are so prominent in low-income neighborhoods. So yes, there absolutely is an element of choice there, and that was definitely something that they looked at as well. Yeah. So even when you sort of control out, one of the problems with the choice question, though, is that sometimes patients aren't given the choice. The physician sort of makes the decision on whether to refer for a procedure or not, and the patient doesn't know that they had other options. Yeah, good. Thank you. Good question. All right, so let's look at where this bias comes from and how it expresses itself. So the first thing is, I'm going to switch from the language of bias to implicit association. And the reason I'm going to do that is because the term bias gets people defensive. Implicit association means that we are socialized to form certain kinds of associations with certain kinds of category memberships. So when we think of category memberships, we're thinking of, what do I notice? What do I see? How do I default categorize people when I'm just passing them on the sidewalk, right? Okay, I'm gonna say right now, my default categorization is like, do you have a mask on or not? Maybe not when we're on a sidewalk because we're outside, but right, anywhere else, I'm like default categorizing mask, no mask. But that's not what I'm socialized for, right? I'm socialized to notice racial differences, to sort of read in people's bodies a question. How do they identify? Are they Black, white, Asian, Hispanic, Indigenous? We're all socialized for that. We can claim to be colorblind, but we're just lying to ourselves. When we say colorblind, for the most part, I think we mean that I try not to act on having noticed those racialized differences, but I do notice them, and anybody kind of stewing in American juices will also have been socialized to notice racialized differences. We notice as a baseline human condition, differences in gender expression. There's a good evolutionary reason for that, right? We're thinking about who's a potential mate. We also baseline kind of just evolutionary, what's programmed for, we noticed age differences. And again, that's got to do with, choice of mate. So when you think about these kind of basic categories, we tend to walk along and go, oh, like older Asian woman or younger Black man, or right? We do that in our minds. And the question is, what do we associate with those category memberships? What are we socialized to associate with those category memberships? When we deny to ourselves that we notice those category memberships, what we do is default to pre-existing associations that are given to us rather than interrogate them, right? So if I say, oh, I don't see color, I'm actually more likely to replicate patterns of social power than if I admit to myself, oh, I see a young Black man there and I know exactly what my society wants me to associate with that, right? My society wants me to say, young Black man, you'd better be afraid, possible criminal, right? That's what I'm socialized for. If I hold up, I see a younger Black man, but I don't actually know this guy, right? If I give myself that pause, then I'm less likely to replicate patterns of social power. But if I don't give myself that pause, then we see what happens here. Black patients are less likely to receive pain medications. This was a study of EMTs. We also have a study of emergency department physicians on long bone fractures. So a long bone fracture is just objectively painful. You can't fake it. You wouldn't be in an emergency department drug-seeking behavior with a long bone fracture if if your leg is broken, you're in pain. And what they found is that even for a long bone fracture, there are huge disparities in prescription of analgesics to manage the pain. So that's likely because we're socialized to associate things like what that nursing textbook said. Oh, he's probably exaggerating pain, probably seeking drugs, right? So we've got these implicit associations driving some of these disparities. We also have structural shifts driving these disparities. So this slide I am just lifting right out of a beautiful article by Dorothy Roberts and Jonathan Metzl, which is called Structural Competence. And what they're looking at is how changes in things like the DSM affect the way diagnoses get made. So in 1954, the DSM described schizophrenia primarily in terms of feeling anxious and uncertain and of neglected and undervalued. And the typical example of a patient likely to be schizophrenic was a white suburban housewife. Disproportionately, white suburban housewives were diagnosed with schizophrenia. In 1968, I think it was, I may have that year wrong, it's pretty close to then, a new edition of the DSM came out and it redefined schizophrenia in terms of aggression and hostility. And within a decade, we had a huge disproportionate share of schizophrenia patients who were diagnosed schizophrenia patients who were African-American men. So this is an advertisement for Haldol, which is a schizophrenia drug. Let me just ask you to read the image. So by read the image, I mean, what do you see when you're looking at that?
Stereotype on top of stereotype.
What kind of stereotype?
Threatening.
Threatening.
Black.
He's Black.
Got that Black power fist up.
Yeah.
Look at that fist.
Yeah.
Angry. What is this suggesting to you? Bruce, I think I heard something.
Is it me or does he look like James Brown?
He does.
Definitely looks like James Brown.
Danger. I see danger.
Mm-hmm. You see danger?
Angry.
He's angry.
This person is outside and he might get into your house.
You might be looking at him through a plate glass window. I think that's an interesting reading of this image.
It's so urban too, and the building almost looks like it's on fire.
Yeah.
It's urban. It looks like the building might be on fire. He's making the black power fist. This looks like a civil rights protester.
And the image along with the words make it suggest that Black people need to be controlled.
Yeah. Is your patient assaultive and belligerent? He might just be really mad about racism, right? He might be out in the streets protesting. And the suggestion here is if you want cooperation, maybe you should drug this person. And so we did get a spike in mental health diagnoses of schizophrenia for African-American men. Here's what's fascinating. We also got a dramatic underdiagnosis of African Americans for depression and anxiety. So those categories shifted. White people started getting diagnoses of depression and anxiety, and we tend to have a much more kind of sympathetic view of those diagnoses than we do of schizophrenia. And so between the 50s and the 70s, we got this flip-flopping of what white people and what Black people were likely to be diagnosed with. So this is a structural shift, right? It's not like it's just the individual bias of a healthcare provider who's been socialized to have certain kinds of associations. This is actually the DSM combined with advertising for drugs, actively suggesting to healthcare providers that your patient might have a mental illness that you're overlooking because what you see is just the anger about, civil rights violations.
And Haldol is just like knock you into zombie land, a quick acting medication. And so just pop a pill, give this person a pill, and you're in charge.
Yeah, and thank you for that. I tend to avoid saying things like that because I'm not a healthcare. I mean, my PhD is in religious studies, for crying out loud. I try to be careful about making claims like that. But yeah, and if you look, it's cooperation begins. So this is a drug to get cooperation. So here's a place where we see structural shifts and implicit associations colliding. In 1989, as a result in some shifts in federal regulations, hospitals were encouraged/required, it's complicated, to report as a criminal offense mothers who, pregnant women who tested positive for drug use. And this is the era of the crack baby, right? There's a huge public outcry about crack babies. You see here on the left, the worst threat is the mom herself. By a really significant margin, most of the women being reported for drug use during pregnancy were African-American women. Crack was the drug of choice. The concern was that these children would have all kinds of learning disabilities, developmental delays. In fact, 5 years later, there was a big study about how kindergartens were preparing for the onslaught of crack babies, for the first wave of crack babies. So a couple things about that. The first is that, again, big disproportion. Black women were tested for substance use and white women weren't. And second, even when white women were tested for drugs, they were found to be using substances at the same rate as Black women. So white women and Black women were using illegal substances at the same rate, but white women were simply not getting reported. So the reason they weren't reported wasn't because, oh, they're not using it, or just because we weren't testing, but even when we were testing and finding that their rates of use were the same as Black women, they weren't reporting. But then you also get this shift in who gets our sympathy. For the crack mom who was associated with Blackness, the threat is the mom herself. And that feeds a cultural stereotype about the broken Black family, about Black women as being inadequate as mothers. And then, of course, because the opioid epidemic has primarily been a white phenomenon, it's the white mother. And here you see, we're not showing her face, we're not shaming her. She appears to have a healthy child there. And there's a lot of kind of sympathy for this mother. Last thing about the crack babies. When you control for poverty, the crack babies had zero developmental delays. So it does not appear that the use of crack actually had any of that impact that we were expecting. There were quite a lot of children who were not reading at, third grade level, those sorts of things. All of that is explainable by poverty, by malnutrition. None of it could be attributed to crack. So even the concern that they were hurting their children turned out to be untrue.
And this is the argument for greater diversity, right, among decision makers. So we see it in the criminal justice area all the time, white judges see particularly white female embezzlers as people who just made a mistake, got on the wrong track. And I was embarrassed by some of the sentences I obtained for clients when they were white women in their 30s in front of a 65-year-old white judge. And I assume the same thing happens in healthcare, right? The decision makers as to who gets reported, they see these mothers very differently because so many of them are white, and we just don't have adequate representation of people of color in decision making.
Yeah, we absolutely need to create a better pipeline of healthcare providers that come from different backgrounds. There's just absolutely no question about that. I also feel compelled, though, to note that health disparities are perpetuated by healthcare providers across the spectrum. That's also true for police brutality, right? That police brutality is not just the white cop, and it's got to do with the way we socialize law enforcement officials, and it's got to do with the way we socialize healthcare providers. That's an important thing to remember. We're all stewing in the same juices. Everyone perpetuates white supremacy, not just white people. I'm not trying to get us off the hook, by the way, because we do need better representation, but that alone is not going to fix it. Yeah. But thank you for that.
Kendra, can I just throw in one more side note? Just with this opioid stuff, I have a daughter that actually did her master's thesis about opioid use and abuse in pregnant women. And Tennessee stands out in such a horrible way for the criminalization of these women, when really what they need is methadone and, treatment during the process. So we started out with that Bible verse about being doers and that kind of thing. I know we're talking medicine, but there's political implications in all of this, and our state legislature has not helped these women at all.
Yeah. Even when you look back to the crack, why did we criminalize that? Yeah. Thank you. So this is still true that we've got physicians who are still reporting that they believe all kinds of racial stereotypes. And in some ways, that's because medical school can accidentally reinforce the idea that race is biologically real. So no time to go into it now, but it's not, right? All of the things that make us human, all of the things that kind of affect our health, with very, very few exceptions, like Ashkenazi Jewish women and a certain kind of sort of virulent breast cancer, very extremely rare exceptions. We just do not have a biological basis for thinking about racialized differences. Things like hair texture, skin color, shape of the face, these things emerged as things that we could differentiate long after Homo sapiens had sort of settled into its current form. I would say fixed form, except like evolution doesn't stop. So like there's not a stopping point. But so the way that we divide human beings into racial categories, what seems self-evident to us, only seems self-evident because the way we've been socialized. This is a much longer point that I don't have time to make today. So I'm going to do a really cheap thing and say, take my word for it, we'll revisit that later. Okay. Nevertheless, in med school, physicians will learn, physicians in training will learn over and over and over again that certain kinds of health conditions are more prevalent in certain populations. Just factually, that's true, right? We have higher rates of diabetes, hypertension, stroke, infant mortality among African Americans. One of the problems is that they can reinforce this idea that, oh, it's the biological difference, it's being Black that causes those things. It's not. Being Black doesn't cause those differences. Racism causes those differences. That's that thing I said at the beginning about social forces are making us sick. Okay, what's that got to do with anything? Well, when you keep getting it reinforced, this sort of association with bodily differences and racialized identity, it can lead you to some pretty ridiculous beliefs, such as the belief that African Americans have higher tolerance for pain, that their nerve endings are less sensitive, that their skin is thicker, that their lungs are weaker. In fact, one of the instruments for measuring lung capacity, a spirometer, up until very, very recently, like maybe last year, meaning that some of them are still, out there, had actually a setting that was sort of a reading that you adjusted for African Americans. That reading stems from a post-Civil War era experiment that tested a Black population lung capacity against a white population, but they tested Black coal miners against white rural population. So of course their lung capacity was different, but in any case, that became the standard. It never got fixed. I can give you the citation on that because it's so bizarre, you almost don't want to believe it. So these kinds of stereotypes, this belief that lung capacity, skin thickness, nerve endings. And here we've got a study, this is a 2018 study of medical students and residents and these various kinds of false beliefs. The good thing is that you see it declines over time. By the time they get to residency, they are fortunately less likely to believe some of these things, but still have pretty high rates of, kind of shockingly high rates of believing things. Like for instance, that Blacks age more slowly than whites, that their skin is thicker, that they have a better sense of hearing than white people, that they have a stronger immune system, and that they are better at detecting movement than white people. So kind of, none of that's true.
It also is dehumanizing. The smell and the sense of, like you're more like an animal. It's infuriating.
Oh, you're more like an animal, right? I mean, my dog has a better sense of smell than I do, has a better sense of hearing. Absolutely. Now here's another one. So we've looked so far at implicit associations and structural shifts, right? Now I want us to look at these hidden systems that perpetuate racism. So this has got to do with the computer algorithms that help physicians make a diagnosis and help them decide what course of treatment to recommend. So, the computer systems are written by people, right? And so the bias of the people will get written into the computer system. Got a couple of examples of this. This one, the headline here is about a study that had to do with who was referred for angioplasty. And the hospitals using this system were consistently referring white patients for angioplasty at a much higher rate than Black patients who presented with the same symptoms. And what they discovered when they thought, well, it's physician bias. And so they checked on that. They kind of checked for everything they possibly could. And what they ultimately traced it back to was that the physicians were relying on this computer system that ranked acuity, so how serious the problem is, correlated that with healthcare utilization. So the assumption was that the more healthcare you're using, the more serious your condition must be. And of course, because of racialized poverty, African Americans are less likely to have kind of the platinum insurance plans that white people do. They are less likely to be able to afford to come into healthcare settings at all kinds of times. And because of some of the stuff we just looked at before, are less likely to trust healthcare providers and therefore might not come in, when symptoms first begin presenting. For all of these reasons, white people are using healthcare more than Black people are. If your computer system ranks acuity with utilization, white people are always going to look like their condition is more serious than Black people. Did that explanation make sense, or did I just muddle that up and you can't even tell what I'm talking about?
It was very clear.
Okay.
Makes sense.
Girl, you're thinking like that's muddled, but I'm not going to tell her. Okay, so here's another example, and this is the one that has me really concerned right now. If we get into a surge situation with COVID-19 and ventilators become a scarce resource, we're going to have to think about how we decide who gets a ventilator. One of the reasons I'm worried about this for lots of reasons, including that I co-chair an ethics committee at a hospital, and I don't want to be making these decisions, right? So we rely on triaging systems. These are computer programs to help us triage patients. One of them is called Apache 2, for instance. And what it does is, I should ask one of the physicians on the call to explain this better than I can, but basically what it does is predict likelihood of organ failure in the coming 24 hours. And so the more comorbidities you have, specifically things like diabetes, hypertension, respiratory illnesses, the more comorbidities you have, the more likely you are to experience organ failure over the next 24 hours. So when we're doing our triaging, the idea is that you want to give the ventilator to the person who's most likely to benefit from it, right? When you have racialized disparities pushed by social forces like racism and racialized poverty, you're going to end up in situations where Black patients are disproportionately likely to have bad Apache 2 scores, right? Disproportionately likely to have the comorbidities that are inconsistent with good COVID-19 outcomes. And that means white patients are disproportionately likely to get those ventilators. That scares me because we already have a problem with trust. We already have a problem, not because Black communities are superstitious, but because historically, healthcare has been untrustworthy. And even though this is innocuous in the sense that nobody intends ill, it could nevertheless reinforce that dynamic if we start to see significant numbers of Black patients dying of COVID-19 because they aren't getting ventilators. Fortunately, that's not happening right now, but it's something we need to be really thoughtful about. I commented on this early in the course of the pandemic as a concern I had. The newspaper called me and asked for a quote. I'm going to have to learn not to give quotes when newspapers call and ask for it. I gave a quote and I got some very, very angry responses from physicians saying, don't tell people that. It's, you know, it'll undermine trust if they know that's a possibility. And so I want to address that too. The thing is, paternalism has not done well for medicine. The idea that if you don't tell people, they won't find out, that hasn't worked very well. And in fact, not telling people and then them finding out has actually undermined trust even more. So I think we're better to be really transparent, even when we don't have a solution for a problem. Okay. All right. This is where I was going to go today. This is I'm not a neuroscientist. This is a warning. We will come back to this next time. We'll do some thinking about why our brains function in this way and some kind of modest proposals about how we can address these kinds of disparities. Okay, I think we're at 10:40. Elizabeth, what time do we go? Do we have time for conversation or do we have to go?
This is generally when we end our conversation. But I think we can probably take a minute or so for any questions for Kendra. I think Julie has a question.
I do. I am really glad that my family has planned a 3-mile hike this afternoon because I'm going to need one after I'm feeling kind of fired up and pissed off. I hope I can say that. Anyway, I'm really glad that this is a two-parter and that next week you're going to come and tell us what we can do. And I know you and how you teach. And so I know we're going to hear about what we as a society can do. And I just hope, because you have a week now, can you have like one slide about what individual, just regular citizens, like I don't sit on a board where those decisions are going to be made. My husband's a healthcare provider, but I'm not. You know, I can try to work on my implicit bias and I know what to do at the voting booth. What else can we as individuals do in our daily lives? And they might be tiny nudges, but I think I would really like to hear about those.
Absolutely. And you will be shocked to learn, Julie knows me well. I'm a structural person. I think about policy. I don't think about individual stuff very much. You'll be shocked to learn that this is the only teaching unit I have where I actually do a workshop on what you as an individual can do. So I'm going to disappoint you though, because it's not going to solve the problem. But it's something. Okay, well, I know this is heavy and I'm sorry. And I also know that we're coming into a week that is scary for all of us, I hope. And so take good care of yourselves in the coming week. And next week when we come back, we're going to be addressing this question of what we as individuals do about these kinds of racist things. And I hope that that'll be a good time to process some of what we're experiencing in this coming week. Thank you so much.
I have a question for Elizabeth and maybe Kendra, is this session going to be recorded and shareable to other interested people?
This, yes, I can see on Zoom right now, this is being recorded. Jenny Brooks will have access to that and we can get it to whoever requests it.
But on a regular basis, it's not posted anywhere, a link to it. I haven't tried to pursue that in previous weeks, but
I do not know if it is posted somewhere, but I can find out.
Okay.
All right. My final announcement for y'all regarding worship is that it is going to be on YouTube. So go to the YouTube channel to watch worship following this. Thank you all for being here, and thank you, Kendra, for this excellent presentation.
Thank y'all.
Right. I'll see you all.
Kendra.
All right. Bye.
Thanks.